Assalamualaikum and a very good morning to all the honorable judges, professors, doctors, lecturers, and fellow friends. Welcome to the 12th UiTM Dental Students Scientific Symposium. Our theme this year is Inculcating Research, Embracing Knowledge. We would like to request all presenters and all symposium participants to fill in the attendance link on our website for the session. My name is Belle, and I will be your moderator for today's poster presentation session, and our timekeeper is Nur Sasha. We are really honored today to have Associate Professor Dr. Nur Azlida Muhammad Noor, Dr. Nur Atika Mat Ashar, and Associate Professor Technologist Dr. Indah Muhammad Amin as our panel of judges for the Dahlia Room. Please allow me to share a few house rules for today's session. First, all presenters must be ready at least 10 minutes prior to your allocated presentation time. All presenters are required to use the provided virtual background in our website for the Q&A session on the scheduled slot. The pre-recorded video presentation will be played by the committee for 10 minutes and subsequently followed by a 5-minute live Q&A session by the judges. For the presenters, please ensure your camera and microphone is turned on only during the session. We will begin shortly. Assalamualaikum and a very good morning to all the honorable judges, professors, doctors, lecturers, and fellow friends. Welcome to the 12th UiTM Dental Student Scientific Symposium. Our theme this year is Inculcating Research, Embracing Knowledge. We would like to request all presenters and all symposium participants to fill in the attendance link on our website for the session. My name is Belle, and I will be your moderator for today's poster presentation session, and our timekeeper is Nur Sasha. We are really honored today to have Associate Professor Dr. Nur Azlida Muhammad Noor, Dr. Nur Atika Mat Ashar, and Associate Professor, Technologist Dr. Indah Muhammad Amin as our panel of judges for today for the Dahlia Room. Please allow me to share a few house rules for today's session. First, all presenters must be ready at least 10 minutes prior to your allocated presentation time. All presenters are required to use the provided virtual background in our website for the Q&A session on the scheduled slot. The pre-recorded video presentation will be played by the committee for 10 minutes and subsequently followed by a 5 minutes live Q&A session by the judges. For the presenters, please ensure your camera and microphone is turned on only during this session. First bell will be rang at 4 minutes of the Q&A session, and another bell will be at the end of the Q&A session. After the Q&A session ends, the moderator will cue to the next presenter. In case of any technical difficulties during the video presentation or the Q&A session, the other presenter must be on standby should be allocated time to be brought forward or earlier. I have an announcement to make just for the judges' note. Unfortunately, participants with the ID EI08 and EI14 will not be able to join us today. Without further ado, let's start our first recorded poster presentation by Maria M. Joss with their research topic, Three-Dimensional Visual Treatment Objectives, The Future is Now.
Good morning. Myself, Maria N. Jose of Coorg Institute of Dental Sciences, Virajpet, Karnataka, India. I am honored to get this opportunity to present a case report where three-dimensional visual treatment objective aided in treatment planning and patient education. Moving on to the case report, we'll take a tour through the introduction, chief complaint, clinical examination, radiography, diagnosis, treatment plan, VTO, surgical phase, results and conclusion. A 24-year-old female patient reported to the department with the chief complaint of unaesthetic smile. The patient was concerned about forwardly positioned lower jaw. Clinical characteristics. On extraoral examination, the patient had asymmetrical leptoprosopic face with a concave profile, prominent chin, deficient midface, flat cheekbone contour and positive lip step. Intraoral examination showed Angle's class 3 type 3 malocclusion, overjet of -1 mm and a crossbite with respect to 1-2 and 2-1. The maxillary and mandibular arches were well aligned with slight crowding in the mandibular arch with all permanent teeth present and good oral hygiene maintained. On cephalometric analysis, the patient is skeletal class 3 due to mandibular prognathism, retroposition maxilla, upper incisor proclination, and lower dental retroclination produced by physiological compensation. Diagnosis: the patient is skeletal class 3 due to maxillary deficiency, prognathic mandible. The patient showed Angle's class 3 molar relation bilaterally. The problems to be addressed include concave profile, skeletal class 3 malocclusion, Angle's class 3 molar relation bilaterally, and a reverse overjet of 1 mm. We'll look into the treatment planning now. One of the greatest challenges in orthodontics is the treatment planning to achieve a well-balanced occlusion, proper function, and harmonious facial aesthetics. We should always start with the end in mind. The orthodontic treatment planning is three-dimensional. It involves three planes: the lateral view by lateral cephalometry, frontal view by anterior-posterior cephalometry, and the occlusal view by occlusiogram. The severity of skeletal class 3 malocclusion may affect the facial aesthetics to the extent that orthodontics alone may not be the treatment. In such cases, an ortho-surgical treatment is necessary to provide satisfactory results. For our patient, the treatment was planned in 3 stages: pre-surgical, surgical, and post-surgical orthodontics. And here is when we encountered the real challenge. The patient is scared to undergo surgical procedures and is worried about her facial appearance. A conventional VTO and cephalometric tracings were used to educate the patient. It was not effective in convincing the patient, rather she was even more confused. And that's how our thoughts landed the possibility of a personalized 3-dimensional visual treatment simulation, VTO. VTO is a treatment planning and communication aid. It helps us predict hard and soft tissue changes that may occur by surgery or by the use of a functional appliance. It also helps in communication with surgeons in orthodontic cases. It helps in growth forecast and patient education and motivation. The threefold functions of 3D VTO. Firstly, to establish the pre-surgical orthodontic goals, to develop an accurate surgical objective that achieves the best functional and aesthetic results, and to create a facial profile objective that acts as a visual aid in consultation. A picture is worth 1,000 words, and this is the pre-treatment VTO created for our patient to help in patient education and motivation. We say beauty lies in the eyes of the beholder, and aesthetics is very subjective. Many times, orthodontists may have a different perspective from the surgeon. Aesthetics that both the orthodontist and the surgeon agrees on may not be what the patient has in mind. Ultimately, patient is the king, and their opinions must be valued and accepted as long as it doesn't compromise on form and function. We used this VTO to help the patient understand the changes that can be made and set realistic expectations. Back to the case history. Pre-treatment lateral cephalogram was digitalized and evaluated on Dolphin software. The pre-treatment photograph was superimposed on the lateral cephalogram. Treatment simulation was done with 4 mm anterior sagittal movement of maxilla and 7 mm mandibular setback. After lip repositioning, the profile was found to be satisfactory. A multidisciplinary team approach is inevitable when recommending surgery for a patient. Here, the treatment was carried out in 3 stages: pre-surgical, surgical, and post-surgical orthodontics. Pre-surgical orthodontic phase. After initial assessment, the pre-surgical phase was initiated with the goal of achieving arch coordination. The decompensation of maxillary and mandibular arches were done to gain a negative overjet by extraction of 1/4 and 2/4. The pre-surgical features show the performed decompensation for the surgery. Moving on to the surgical procedure, a bimaxillary surgery with maxillary advancement of 3 mm and mandibular setback of 7 mm after pre-surgical decompensation of the arches were performed. In the mandible, a bilateral sagittal split osteotomy was conducted for mandibular setback, and Leaford 1 was performed for maxillary advancement. Rigid fixation was placed in the maxilla through the use of 4-hole mini plates and a screw on both sides. An intermediate splint was used to secure the mandible in correct position. Intermaxillary elastics were used for 30 days during the immediate post-operative period to achieve maximum stability. Post-surgical orthodontic phase. Active orthodontic treatment was resumed 4 weeks after surgery. The objective was to achieve ideal occlusal relationship in terms of canine and molar relationship, overjet and overbite, and matching dental midlines. During post-surgical orthodontics, 1925 SS arch wires were maintained. All the residual spaces were closed, and intercuspation was refined with 1925 braided arch wires and short intermaxillary elastics. Post-treatment, the patient had ideal overjet and overbite of 2 mm and concordant midlines. The case was finished in Class 2 molar relation, Class 1 canine relation, and canine guided occlusion. It is important to highlight that a good retention helps maintain the final occlusion that is achieved surgically and a long-term occlusal stability. The patient was extremely happy with her new smile and aesthetics, and this gives us a boost to create more beautiful smiles and pretty faces. Thank you.
Now, we would like to invite the judges for the Q&A session.
Thank you for your presentation. May I ask, what are the advantages or disadvantages of using this method compared to the conventional method? Because you're using 3D, right?
As we are using a three-dimensional treatment objective, we can see three planes, ma'am. It allows visualization in all three planes, and on a computer field, we can change the field in any. Both the soft tissues and the hard tissue prediction can be done in very well in three-dimensional treatment. In conventional VTO and cephalometrics, only two-dimensional approach can be made. And in three-dimensional approach, even the soft tissue profiles and the final outlook of the face can be determined even before the start of the surgery and even before the start of the treatment. So we can educate the patient and set realistic expectations as to how and when the treatment will be completed and what will be the phase after the treatment procedures.
Okay. May I ask? Thank you for your presentation. You mentioned in your abstract that the final results shows 90% success rates. May I know how did you come up with the value?
Our postgraduate had conducted a study based on like 10 cases that was performed in our college. We had a study and when comparing the pre-treatment VTO and the final results that we achieved, we compared the values. We took three values, Nasion, point A and point B values, and then compared.
Oh, okay. So it's not it's a combination from other cases as well.
Sorry,
Sorry,
ma'am?
I didn't quite hear you. So you mentioned the postgraduate did the analysis?
Yes, ma'am.
Okay, so
We
it's a
compared the
combination,
pre-treatment and post-treatment results, ma'am.
right? Together with other cases, not just your case, right? Because you
So
are reporting one case, right?
I was talking about my case, ma'am.
Yes, that's
Again,
right.
other
So the
cases that
okay, all right, okay.
Hello, Maria. Can you hear
yes,
me?
ma'am.
Okay.
Yes, ma'am.
You mentioned about the VTO as one of the aid to educate the patients.
Yes, ma'am.
Is there any other method beside that? Maybe you can maybe like media social or something like that to educate the patient.
I didn't get the question,
To
ma'am.
explain the treatment. Okay, you mentioned about the VTO, isn't it?
Yes, ma'am.
Is any other method beside that?
Actually we started with a cephalometric tracing and conventional methods to educate the patient, but the patient was more worried how the outlook will be like after the surgery. We are going for a surgery, how the face will be after the surgery. The patient was very confused, and she was actually willing for the surgery, but she was confused. That's why we used VTO so that the patient can see how she looks even before the start of the surgery, and we can convince the patient. We also
Okay.
used YouTube videos to show the patient how each and every procedure is conducted. But
Okay.
she was more convinced and happy when she saw her own face in the
Okay.
final results, ma'am.
Okay. Okay. Thank you. That's all for me.
Thank you so much.
All right. Thank you to all judges and presenter. Moving on to our second poster presentation, please welcome Pratishka Kalapa with the topic of the influence of skin tone on bite marks on their analysis.
Pleasantries to all. The title of my presentation today is Can Complexions Cause Complexities? That is, the role of skin tones in bite mark analysis. Bite marks are a very important part of this emerging field of dentistry called as forensic odontology. Forensic odontology is that area of dentistry that deals with the correct management, examination, evaluation, and then the presentation of dental evidence in criminal and civil proceedings. So now let us understand what are bite marks. Bite marks are nothing but physical alterations in the medium. Medium is that part where the bite mark has been inflicted, mostly caused by the contact of teeth and related structures, which leaves behind a representative pattern on the object or the tissue caused by dental structures which might belong to an animal or human beings as well. As mentioned earlier, bite marks play a very important role in forensic odontology. Matching the bite mark that we recover from the site of crime will help us connect the suspect to the crime and will also help us in proving the victim to be innocent. When we analyze a bite mark, there are certain factors that we need to take into consideration, and this is mainly because there are a lot of factors that influence bite mark analysis. The factors that influence bite mark analysis includes the skin elasticity, the skin tone, the anatomical site at which the bite mark is inflicted, the age of the victim, permanency of the bite mark, and also the uniqueness of bite mark. There are various materials that we used for this study of mine. First, we used photographs that were clicked at 0R and 1R of the inflicted bite mark. We used the GIMP software to trace the bite marks and also a skin tone chart to compare the skin tone of the subjects to subjects and determine the kind of skin tone of that individual subject. The subjects of my study included 15 students of our own institution who were willing to take part in this study of mine. The very aim of my study was to show how skin tone acts as a factor which affects the analysis of bite marks, and also to understand how the skin retains a bite mark mostly based on its tone over a period of an hour. The methodology of my study went something like this. In the first step, we compared the skin tone of our subject with a standardized skin tone chart. After the skin tone was determined, we asked the subjects to inflict a bite mark on their forearm. This was a self-inflicted bite mark. Then, a picture was clicked at 0R, 0R meaning the time as soon as the bite mark was inflicted on the forearm. And then we waited for 1 hour, a period of an hour, and this was to understand the different changes that can occur in the skin tone based on it, the different changes that can happen in the bite mark based on its tone. After this, we clicked a picture at 1 hour. All of these pictures that were clicked at 0R and 1R respectively were then blinded and sent to a forensic odontologist to assess the ease of tracing. Then both these pictures were compared. After this, what we could determine was some of the lost and the retained features, and also understand how how skin tone had actually influenced bite mark. Some of the problems that we faced during this entire course of my study included: 1. The force of infliction. The force of infliction of bite mark was not standardized and it did vary from one subject to the other. The second was the light. Yes, we did click the picture under natural sunlight, but I do believe that because of the light there can be certain variations in the skin tone of an individual. After this, we determined some of the lost and the retained features. The retained features of bite marks after an hour included the initial outline of the arch and also the shape of the arch. The incisive bite marks were very well retained. This is mostly because during any kind of infliction of bite mark, the anterior teeth tend to apply more force as compared to the posterior teeth. The features that were lost included: 1. Ecchymosis was lost or was not very evident in darker skin individuals after a period of an hour, and also the initial arch form and the outline which was very well defined at 0R had become more diffuse. And the third most important thing was the initial depth of the bite mark was lost was lost. Now coming to my results, at 0 hour as mentioned earlier, the bite marks were very well defined. At 1 hour, the margins of these bite marks had become more diffuse. Drag marks were produced better on darker skin individuals, and the most important finding is of that of ecchymosis. Ecchymosis was very much evident on lighter skin individuals as compared to darker skin individuals. This finding of mine can be attributed to the anti-inflammatory effect of melanin. The anti-inflammatory effect of melanin subsides any kind of signs of inflammation. And as we all know, darker skin individuals have more of melanin, therefore ecchymosis is less evident in darker skin individuals as compared to lighter skin individuals. These were the results of my study. So now if somebody poses a question like, can complexions really cause complexities? The answer would definitely be a yes. To conclude, I would like to say that although bite marks are used worldwide in many criminal prosecutions as an evidence, still there are a lot of questions being raised, mostly on its accuracy and also on its reliability. This is not really true. As mentioned earlier, if we consider different factors, not just the skin tone of an individual, but also different factors that influence bite mark analysis like the skin elasticity, the age of the victim, the anatomical site at which the bite mark is inflicted, the force of infliction, etc., we will definitely be able to bring a proper we will definitely be able to prove that bite marks are really accurate, and there will be very less wrongful convictions or any kind of mismatches at all. Being very well informed will increase and improve the credibility of bite marks as an evidence. To conclude, I would like to say consider before beginning. Saying so, I would now like to end my presentation. Thank you so much.
Thank you very much for the presentation. Now we would like to invite the judges for the Q&A session.
Okay. Good morning, Pratiska. Is that correct?
Good morning, ma'am.
All right. Thank you for your presentation. It's always a very nice presentation, but it's always a gray area in forensic when you talk about bite marks investigation. It's good that you are interested to do in such work, but I would like to clarify a few things from your abstract. You mentioned that the bite marks was self-inflicted, and you also did mention that it's a bit difficult to standardize the bite made by the subjects. But how did you minimize that variation? What was the instructions given to the participants to do the bite?
Ma'am, to standardize the bite marks that were inflicted, the force, obviously, we couldn't really standardize, but the
Yeah.
time of infliction, we just gave it to be like 10 seconds.
That's all was the instruction given to the participant? You just bite
Yeah.
for
Yeah,
so
ma'am, that is because we also wanted to retain it to be more natural. Because in any circumstance, the bite mark that will be inflicted in any crime or something, it will not really have a standardized pressure that is applied. So we try to keep it natural. The only thing we said was the time, ma'am, the time
okay.
limit.
All right. You also mentioned that your subjects were dental students from your institution, correct?
Yes, 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 ma'am.
What was your inclusion criteria? Is there any inclusion criteria for this, or all any dental students who are interested to participate, you will recruit them?
Yeah, it was nothing like an inclusion criteria. We just wanted people based on their skin tone. So we tried to choose people who are like a little lighter skin tone and a darker skin tone individuals. But then inclusion criteria as such we did not have, because people who are interested to take part in this study, because it's a pilot study, so we
Yep.
really didn't include a lot of inclusion criteria, ma'am.
Okay, just one more from me before I pass to other judges.
Sure.
Did you look at the alignment of teeth when you analyze the results?
Yes, yes, ma'am. We did analyze. For that, we used this GIM software. We tried to recreate the features that were retained using a pen,
Oh,
and
no, no.
then
What I meant is, were there like a very high range of types of malocclusion among them, or are they
oh,
all well aligned? Do you
yeah,
actually?
ma'am, yeah, ma'am. Oh, malocclusions. We then include students with malocclusions
Oh, all
this
right.
time, but it was just a normally aligned teeth. It was
So,
natural.
they were all well aligned. Okay, all
No,
right. Thank
yeah.
you.
Thank you, ma'am.
Hi, very good presentation and very interesting study. I just have one question. Because you did mention there are several factors, right, affecting,
Yes,
you
ma'am.
know, skin tone, age, and so on. So I'm just wondering, in when you talking about selecting the samples. So when you say you select, you try to have darker skin tone, lighter skin tone. How you do that? You have specific way to measure to be in a darker skin tone group and the other one
Yes,
in the lighter
ma'am.
skin tone group.
Yeah. Ma'am, we had this skin tone chart, and then we compared the skin tone chart with the skin tone of the individual under natural sunlight, and that was how we were able to determine the skin tone of that individual, ma'am.
The, one more from me. Have you heard the term there is a project called Innocence Project? Have you heard that?
Yes, ma'am. California Innocence Project.
All right. Do you have any comments with regards to your
Uh,
research about that
yes,
project?
ma'am. Yeah, the California Innocence Project, yes, it was
That,
disapproved. But then, yeah, if we are like how I mentioned earlier, if we consider different factors like skin tone, people might think it is like really menial, like it's not really important when you're analyzing a bite mark. But then when we really get into the depth of that study, when we get into the depth of that factor, everything will be will become important, and it will definitely influence bite marks. So, ma'am, being better informed about that bite mark will definitely increase the credibility of bite mark as an evidence, according to me, ma'am.
okay. All right. Good that you are aware of that project. Thank you.
Yeah, thank you, ma'am.
Uh, Hi, Pratiska. Okay,
Yes, ma'am. Good morning.
based on your findings in your study, what do you think? Your opinion, your own opinion, how much the bite marks can help the analysis? I mean, the credential of the crime besides other factors.
Sorry, ma'am, I couldn't get your question.
Okay, based on your findings, okay, in your own opinion, how much, I mean, the percentage of the bite marks analysis can help the credential, can be the good credential for the crime.
Okay, ma'am. Based on my study, if we also, along with considering skin tone as a factor, if we consider the normal arch, like how I mentioned earlier, for my case, we did not take any malaligned teeth and all of that. But if in case the real arch, the real shape, and all of that is considered, I think bite marks are actually credible enough to connect the suspect to the crime, ma'am.
In what percentage?
Percentage,
The-
I don't know, ma'am. I really can't give a percentage.
Okay, that's all. Thank you, Pratiska.
Thank you, ma'am.
All right. Thank you to all the judges and presenter. Now, moving on to our next poster presentation from Dia Rajeswari with the title Nanotechnology in Oral and Maxillofacial Surgery.
Hello all, we are here to present e-poster on the topic nanotechnology in oral and maxillofacial surgery. Nanotechnology is the branch that deals with dimensions and tolerance of less than 100 nanometers, especially manipulation of individual atoms and molecules. It can be considered as science of small. Oral and maxillofacial surgery, which is considered as bridge between medicine and dentistry, cannot turn away from accepting this fast development in era. We are going to present some of the uses of nanotechnology in oral and maxillofacial surgery. Imaging. There are many types of imaging modalities commonly used in oral and maxillofacial surgery. The more important use of three-dimensional imaging has allowed for advances in the field of oral and maxillofacial surgery. The advances in 3D imaging and surgical software programs have allowed for improved surgical planning and creation of patient-specific surgical guides and implants. Second use, dental implant. Dental implant is regarded as one of the ideal solutions for occlusion reconstruction. With aid of nanotechnology, implant surface modification from macro to nano scale enable overcoming limitations of bone-like structure. Nowadays, composition of bone are similar to biological nanocomposite. Nanoparticles which are used in dental implants are titanium dioxide nanotubes, carbon nanotubes. So far, nanotechnologies of surface coating or modification such as surface modified by titanium dioxide nanotubes or nanorods, coating by nanosized calcium phosphate and calcium silicate compounds, carbon nanotubes has been used for dental implant surface modification. The next use is in oral cancer therapy. Nanoparticles used in cancer therapy are polymeric nanoparticle, useful carrier for targeted delivery of anti-cancer drugs. It enhances stability of drugs and reduce side effects of drugs, provide excellent intracellular uptake, minimize cytotoxicity, and provide excellent anti-tumor efficacy. Then magnetic nanoparticles are used to kill tumor cells by applying heat over 50 degrees Celsius and cause cell necrosis. Nanoliposomes have advanced efficiency, biocompatibility, nanoimmunogenicity, and ability to encapsulate a wide array of drugs. The next use is salivary gland tissue regeneration. Salivary gland play an important role. The damage or disease of salivary gland cause of radiotherapy have adverse effect in oral health. Thiolin photopolymerized PEG hydrogels encapsulated with submandibular gland cells have similar cellular organization as the native gland. PEG hydrogel wall micropattern PCL nanofibrous sheet has been found to greatly enhance formation of spheroids and producing a acina-like structure. PGS, PLGA nanofibers increase cell binding ability of salivary epithelial cells. The next use is drug delivery system. So injectable hydrogels, carrier of therapeutic agents such as drugs, cells, proteins, bioactive molecules in treatment of disease and cancer. Silica-based nanoparticles for dry delivery. Uses Tmj Cartilage Regeneration. Tmj is a critical articulation which manages the movement of mandibular such as mouth opening, closing, and chewing. It is composed of a typical bone cartilage interface and a synovial disc, forming a complex bilateral synovial of which the disc plays a critical role in TMJ functioning. For example, nanofibers has been widely applied to reconstruct cartilage defect as well and showed significant effects in vivo. And auricular cartilage regeneration, nasal cartilage and auricular cartilage play a critical role in maintaining the appearance and function. Different from auricular cartilage in TMJ, nasal cartilage and auricular cartilage has a specific shape and function. The next use is cranofacial bone regeneration. Cranofacial bone defects could be induced by congenital malformations, trauma, infections, and tumor recession, which causes an impair of cosmetic appearance and dysfunction of maxillofacial surgery. Alveolar bone regeneration. Alveolar bone is the supporting bone structure of the root of teeth. whose stability and structure may be modulated by masticatory function and periodontal inflammation. Defect of alveolar bone is the main cause of tooth loss. Alveolar bone regeneration mainly involves two parts. One is the periodontal disease causes alveolar bone loss, another one is the bone increment for the tooth implantation. The next use, nerve tissue regeneration. Nervous system plays a leading role in body, which control and regulates the activities of organs and systems. Neuron is the most basic structural and functional units of nervous system. Neuron damages are mainly caused by the lack of effective self-repair mechanism of neural tissue in the human body. Nanomaterials-based nanotechnology have provided new insights into the repair of irreversible damaged neural tissue. Nano-sized carbon has been introduced into vivid, flexible, and stretchable electronics for variable devices and implants with superior performance in terms of sensitivity, elongated morphology, and resolution compared to traditional methods in ex vivo and in vivo environments. Thank you.
Thank you for the presentation. For the judges, we may have a 1 minute break because the participant cannot enter the stream yet, and we will be back to you soon. All right, now we are back. So now we would like to invite the judges and the presenter for the Q&A session. Is the presenter there?
Are you there, Dia?
Hi, yeah, you there?
Hello, Dia.
Mute. To all the judges, is it possible for us to move on to the next presenter? Because we are still cannot contact them regarding of their technical difficulties.
Okay, sure.
All right. So we will contact the presenter later. Now we proceed with our next presentation. Gayatri. From Gayatri S. Chandran with the title Intraoral Photograph in Forensic Odontology.
Science is simply the word we use to describe a method of organizing our curiosity. It is a capital mistake to theorize before you have all the evidences. It biases the judgment, right? A warm and pleasant day to one and all present here. My topic is intraoral photographs in forensic odontology. Before I move particularly onto the topic, I would like to give a brief introduction on forensic science as well as forensic odontology. Forensic science deals with the application of broad spectrum of sciences to answer the questions of interest to the legal system. Forensic science is also known as criminalistics. Forensic odontology. Forensic odontology is derived from a Latin word forum, which means court of law, and odontology is the study of teeth. Forensic odontology is a branch of dentistry that deals with proper handling, examination, and evaluation of dental evidences, which is then presented in the interest of justice. Forensic odontology has three major areas of utilization. Number one, diagnostic and therapeutic examination and evaluation of injuries to jaws, teeth, and other oral soft tissues. Number two, identification, examination, and evaluation of injuries, especially in casualties like mass disasters and criminal investigations. Number three, identification of bite marks, which occur with some frequency in sexual assaults, child abuse cases, and in personal defense situations. The odontological identification is based on pre-mortem and post-mortem dental characteristics of the victim or based on any other dental records of the victim. The new millennium has brought many good things to our lives, along with new challenges of terrorism, man-made disasters, natural disasters, and high rate of crimes. Forensic dentistry aids in the identification of victims in cases of absence of fingerprints, personal defects, and in other cases of disastrous incidents like aircraft mishap, where fragmentation and thermal injuries are more common and where bodies are grossly decomposed. On the other hand, orthodontics is a dentistry specialty that addresses the diagnosis, prevention, and correction of malpositioned teeth and jaw and malocclusion. It may also address the modification of facial growth known as dentofacial orthopedics. Orthodontics, like any other specialty, has much to offer in medico-legal investigations. Dental records. Dental records, also referred to as patient's chart, is an official dental document which records all of the treatment done. Orthodontic records are of high forensic values. So meticulous maintenance of diagnostic and treatment orthodontic treatment records will be helpful in forensic identifications. There are dentists who still use paper patient records stored in file cabinets or shelves. Increasingly, they are incorporating new technologies into their practice to manage large number of existing records. Moving on to ways of identification. Bite mark analysis. It is based on the principle that no two mouths are alike. Bite marks left on chocolates, other food materials, cigarettes are also encountered. Bite marks, if analyzed properly, can prove the involvement of a particular person in crime. Next, palatal rugae. The different and unique patterns of palatal rugae may be helpful in identification only if ante-mortem records exist. It also aids in sex identification. Radiographs. The post-treatment radiographs are important tool in identification as orthodontic treatment warrants the extraction of tooth. Facial reconstruction. Facial reconstruction, also known as forensic facial approximation, FFA, is a technique based on both scientific standards as well as artistic skills to rebuild a face onto a skull to recreate ante-mortem appearance of victim's face. Moving on to one of the best and easiest methods of identification, that is using intraoral photographs. The facial or intraoral photographs taken following orthodontic treatment are very useful in forensic identifications. Clinical photographs allow orthodontists to study the case carefully. These photographic informations help them in formulating the best plan for patient's treatment and in monitoring them in subsequent follow-ups. Intraoral cameras are preferred over normal cameras or DSLR cameras. Intraoral cameras are small, lightweight, stylish, and capture high quality colored pictures. There are main classes of intraoral photographs. Number 1, maxillary occlusal view. Number 2, mandibular occlusal view. Number 3, intraoral left. Number 4, intraoral front. And finally, intraoral right. The increased use of extraoral as well as intraoral photographs for treatment plan and execution, along with popularization of digital cameras, is providing more data for human identification in forensic field. As I conclude, forensic odontology is an upcoming branch of dentistry with good scope for development. The tragic incidents of past and present have given an insight to increased importance of forensic dentistry. At the same time, the word forensic orthodontology or the name forensic orthodontology is gaining more importance due to increased use of orthodontic records for forensic identifications. Thus, the importance of forensic dentistry allow the dental clinicians yet another reason to maintain proper records, proper diagnostic and treatment records. That's all about my topic. Thank you and have a great day.
Thank you very much for the presentation. Now we would like to invite the judges and the presenter for the Q&A session.
Okay. Do you guys want to go first, or I can start?
You go on.
Okay. Good morning, Miss Gayatri.
Good morning, ma'am.
Very
Yes,
early,
ma'am. Yes.
very early there, right? At your area, 8 in the morning. Never
Ma'am?
mind. It's okay. Thank you for. We have listened to your presentation just now. I just want to clarify. What type of research that you just shared with us just now?
Ma'am, orthodontic records are more used in forensic identification. So I wanted to put that thing in front of you, like how orthodontics help in such identifications.
Okay. What I meant is, was it a review paper? Did you do a review on the use of intraoral radio?
Review, ma'am. Review, ma'am. Yes, ma'am.
Review. Okay. May I
Yes,
know
ma'am.
how did you do the review? Where did you get the evidence?
Ma'am, I have gone through many articles.
Mm-hmm.
Then I have written all the points. I've collaborated all things like not only intraoral photographs, all other methods of identification, and then have just put.
Okay, so you use did you browse through PubMed or did you use Google?
Google Scholar, ma'am.
Oh, okay.
Articles.
All right. Based on your readings, can you highlight to us have you heard about the admissibility of evidence in forensic odontology? Have you heard the term?
Sorry, ma'am. Can you please repeat, ma'am?
Okay. Based on your literature review, have you come across this term, admissibility of evidence in forensic odontology? You haven't? Okay, it's okay. Can you highlight to us what will be a good quality photos or good quality photograph that we can use in forensic odontology? What are the requirements based on your literature review?
Ma'am, if we use normal cameras or DSLR cameras, it is heavy and we can't record all the features inside, like lingual part properly. When we use intraoral cameras, like it is in form of pen, we can go through the lingual surface properly and we can record clearly the features.
Okay, is there any other things apart from the use of specific equipment? How about
Like use of intraoral cameras, are not very common now. People are clinicians are incorporating such techniques. I'm not aware of any other type of camera other than like pen form or.
All right, thank you. I will pass to other judges.
Hi, I'm Gayatri. So,
Good
yeah,
morning,
good
ma'am.
morning. So, I also at first very not very clear about your study design. Yeah. So, is a review. So, I think just a comment. So, maybe you would like to say that in your presentation or in your abstract so that we are aware. Yeah. All right. So, I think I just wondering what how many database you use for your literature review search? Just one. How many
Ma'am,
data? How many database for your literature review search?
ma'am, it's not clear, ma'am.
Okay, how
Sorry.
many database? How many database did you use for your literature review? You mentioned Google Scholar just now. Is there any other
Yes,
database
ma'am.
you use?
I've gone through more than 5 articles.
Only five? You only include five articles for
No,
your
not
review?
five, more than five. I don't know the exact number. I think I didn't mention it in my
Yeah,
poster.
yeah. We are not very clear. So, is there any inclusion criteria? How actually you decide? This article will go to be placed in my study. How you do that?
Ma'am, I was interested to this topic. When I checked, more of orthodontic records are used for this identification nowadays. So I went through all those type of articles. Then I collected information. I just presented.
Okay, so you don't have any like criteria, like type of studies to be included in this review? No, just everything that you found, then
Uh,
you place it. Is there
Nothing
any
like that, ma'am. It was
nothing
just
like
my
that?
area of interest.
All right, okay, okay.
Hi, Gayatri. Okay, I think
Morning,
the
ma'am.
judge, both of judges already asked my question because I also confused with your presentation. The advice from me is you need to include the citation and also to details your experimental design in your presentation. There is a
Ma'am, can you?
very okay. Can you hear me, Gayatri?
Yes, ma'am. Sometimes it's not clear.
Okay.
I think.
Uh, Actually, I my questions already been asked by both judges. Okay, I agree with the judges that actually earlier part I'm very confused. What are the actually research you do? Okay, so my advice is you need to have the detailed explanation about the methodology or your experimental design, and you need to include all the citation from what you get the all the information. Okay,
Uh,
that's all from me. You want to say something, Gayatri?
no, ma'am.
Okay, that's all from me. Thank you.
Thank you.
All right, thank you very much for the Q&A session. Alright, to the judges, the presenter with ID EI13 is now present. We will be continue with the Q&A session with the title Nanotechnology in Oral and Maxillofacial Surgery.
Hi, dear. Can you hear us now? Hello. You muted. You want to turn on your mic? Can you hear us? Hi, dear. Can you hear us? Hi, dear. Can you hear us? I think you're muted. You want to turn on your
Yes,
mic?
ma'am.
Okay, now you can hear.
How?
Can you hear me now?
Yes, ma'am. Good morning, ma'am.
Yes.
Yes, ma'am.
Okay. Let's go to the question. So I'm just wondering, what is your study design actually?
Ma'am, actually, we have took a topic called as nanotechnology, where the nano means 1/10th of the size. For example, we have to take a nano robots or something like that. In future, nanotechnologies now it's going about the research a lot. So we are interested is like, for example, as we take how these nano robots works in the body and helped us to cure some disease or something like that in oral maxillofacial surgeries and all.
Yeah.
Since we can't insert,
Is
yes,
this
ma'am.
a review? Is it a literature review or you conduct any?
It's we have, yes, ma'am. We have gone through many articles, and then also there are some of our ideas which we even wanted to share later. In this presentation is just like about the articles, but later I'll come to even our ideas and what I have thought about this nanotechnology.
Okay, I think I pass to the other judges.
Maybe I want to ask question. Okay. Okay, mostly you mentioned about the advantages or benefit of the nanotechnology in the field of dentistry. Maybe you can give any example of the disadvantage of this technology to the dentistry?
Yes, ma'am. Actually, we are doing the presentation on the surgery, ma'am, maxillofacial surgery. For example, if you're going to take normal medicines for cancer treatment, we can tell about the malignant cells versus the normal cells, where it might cause a health problem or immunological problem to the patient. So when we go to nanotechnology, it's like we are the nanoparticles or nanorobots which kills only a particular cancer cells rather than killing the normal cells, so that the patient might not cause any immunological problem or health issues. It will be minimal than compared to the medicines or some other surgical ways. So we can tell nanotechnology being a very minute particle, it can help in many cancer issues or something like that, according to my belief, ma'am.
Dia, I can't hear you clearly.
Um, 1 second, I'll just remove my headset.
Ma'am, is it audible now? Ma'am, is it audible now?
Yes.
Ma'am, you want me to repeat this again?
Yes. Can?
Ma'am, as you have asked the advantages of the nanotechnology, so according to my knowledge, just I have thought it, ma'am, as a research or something like that. For example, I took about the cancer. When we take a cancer, if the patient dealing with cancer is going through any medicines or treatment rather than this nanoparticles, these medicines might kill both the malignant cells and also the normal cells. So when we come to, according to my knowledge, if we are going through nano robots or nanoparticles to kill the cells, they might target on the particular malignant cells and kill that rather than killing the normal cells too. So that the patient may be, uh, they might not cause any immunological problems or any other weakness or any other errors. So I feel like nanotechnology is the best process of for the cancer treatments or something like that. In future, it might get even more developing and maybe the best use. Since the nanotechnology nowadays for sutures and all, they use nanomaterial, sutures and all, which are really helpful nowadays.
Um, okay, maybe I can rephrase my question again. Okay, do you find
Yes,
any
ma'am.
in your literature in your literature, do you find any maybe obstacles in this nanotechnology to implement in dentistry? Anything, any obstacles to apply or to implement this technology in dentistry?
Yes, ma'am. There are many. I have in this review. I have given so many like nanocarbon, nano minute particles. We have gone through it, gone through the articles, and we have mentioned some of the materials that we are going to use in dentistry. In like, for example, in auricular cartilages or TMJ or neural system. We have in this review we have gone all through this now.
Okay, okay. Thank you, Dia. Pass to
Thank you, ma'am.
Dr. Atika.
Hi, Dia. Just one from me. Uh, do you are you do you have any idea whether in your institution have you seen any of your lecturers doing this kind of research in your institution?
No, ma'am. Actually, it's no, ma'am. We have gone to so many departments, and then we were going to find something new kind of presentation. So when it come to nanotechnology, we found it like, yes, this might work in future. Nowadays it's everything is being through robotics, mechanical and everything. So why not even dentistry can use this? So we thought like a nanoparticle, it is about something like in dentistry head and neck part. So the nanoparticles might really help in future. So thinking about it, we have by our own interest we have gone to it, ma'am.
Okay. So maybe you can suggest that to your oral surgeon. All right. Thank you.
Thank you, ma'am.
That's all from me. Hmm.
Thank you very much for the Q&A session. Now, we will be moving on to the next presentation from Ashira M. Navia, Aravin Nabia, with their research title, Robotic Telepathology.
Good morning to one and all. Today we are here before you to present on the topic robotic telepathology. Robotic telepathology is a practice of medical diagnosis facilitated by digital transmission of pathological data. Images can be transmitted via ordinary telephone lines, satellites, and internet. It enables a pathologist at a distance to use a personal computer to simultaneously control a robotic microscope and to view the data on a monitor screen. It helps for the employment of a pathologist not readily available at the site of site. The technique of using robotic microscope at the transmitting site by the concept of virtual microscopy has gained a considerable progress for research and education. This technology utilizes digitalization of whole microscopic glass slides via computer-aided systems to produce virtual microscopic slides. Studies related to telepathology are limited to the field of neuropathology and cytology preparations. Telepathology can be classified into three types: store and forward telepathology, dynamic telepathology, and hybrid telepathology. Store and forward telepathology. It involves capturing of still images and transmitting them in an asynchronous mode. Dynamic telepathology. It is a real-time method which transfers video stream from a remote site to the telepathology service with the digital or video camera. Hybrid telepathology. It's a method which combines both static and dynamic telepathology methods. It was Ronald Weinstein who coined the term telepathology in the year 1986. In India, the first exposure was provided at a symposium organized in 50th Annual Conference of the Indian Association of Pathologists and Microbiologists in Mumbai in 2001, and it was named as Telepathology Today and Tomorrow. Compared to the traditional method, it is a faster and easier mode to share images. In case of traditional pathology workflow, after the preparation of tissues, it is couriered, analyzed in lab, and the patient gets diagnosed. But in the digital pathology workflow, after preparation of tissue slides are being created and analyzed digitally and get diagnosed at a faster rate. This technology has a greater significance in the provision of an urgent diagnostic service in the absence of a local pathologist. The distant pathologists have a remote control over the local microscope, and the pathologist having the slide in person is instructed by the distant pathologist at the receiving site.
Robotic telepathology can be used for remotely rendering primary diagnosis, second opinion consultation, quality assurance, education and research purpose. Medical professionals in different locations can view images simultaneously and discuss diagnosis through teleconferencing. Patients' data can be synchronized across various electronic health information systems. Robotic telepathology has not achieved widespread adaptation due to need for someone trained to operate at the remote site. It is expensive due to skilled labor cost. It is expensive to operate than the traditional system. Pathologists have limited control over the slides and images. There is a chance for the pathologist to incorrectly get diagnosed without recognizing the errors. This technique faces a great challenges like quality issues, legal issues, patient's confidentiality, de-skilling, and backup plans. Quality issues include standards like image resolution, color depth that should be captured, speed with which image should be transferred, necessary qualities of any viewing station to ensure that the captured is not degraded. Legal issues. It arises when telepathology service is used from outside national boundaries. For example, in European Union, the registration of reporting pathologies must be recognized by the regulatory body of the European Union member state, an essential requirement in order to maintain proper standards of reporting. In case of patient's confidentiality, expert advice on data protection is needed if patient's identifiable or potentially identifiable information is being transmitted. De-skilling or loss of relevant local expertise can occur if particular category of specimens are routinely allocated to report over a long-term period. Backup plan. Laboratories must have procedures to maintain activities in the events of equipment failure. There must be procedures in place to ensure sufficiently rapid repair or replacement of sophisticated equipments. Although at present, the system is not capable of replacing an on-site pathologist, the results were encouraging and suggest that the remote control, remote diagnosis has the potential to increase the efficiency of pathologists. This method has potential to improve several aspects of pathological practice for the better benefit of patients' care, hoping a better future in the technique of robotic telepathology. Thank you.
Thank you.
Thank you very much for the presentation. Now we would like to move on for our Q&A session.
Hello.
Hello, ma'am. Good morning.
Hi.
Good morning,
Good
ma'am.
morning. I didn't get your name. I forgot. Sorry, Ashira, was it?
Yes, ma'am. Ashira.
Ashira. Okay. Who's the other one?
Navya. Navya.
Navya. Okay. Thank you for your presentation. I from based on your what you shared with us, it's a type of review research, correct?
Yes, ma'am.
Okay. Based on your literature search, did you manage to find out about the validity of this technique?
Yes, ma'am. We have went through a lot of articles, and so
Okay.
we have understood that this method have used in a lot of fields like neuropathology, cytology preparations, like different fields. It have made a great progress.
Okay. Specifically on the value of the validity study, have you managed to find out about it? Like, what would be the if some of the research have actually done in inter or intra observer error using this technique? Did you manage to find out about it?
Ma'am, in frozen technique, frozen section diagnosis, rather than intraoperative touch preparations, it have been used in neuropathologically and cytology preparations.
Okay. What do you understand? Or, when we introduce a technique, what are the things that we look for to ensure that this technique will be clinically useful? Did you manage to find out anything based on your literature search?
Ma'am, manipulation, how the pathologist can manipulate each and every techniques, or how we are using it. First of all, we need to understand how we are using that method, how we have to make it into practice.
Okay.
Then patient cooperative with all these methods.
Okay. So how do you ensure that that method can be introduced in our clinical practice? What are the things that they checked?
Ma'am, we have to be skilled about this technique, and clinically, in the sense like isolated areas, isolated hospitals, this is a very useful technique. And for easier and faster diagnosis, in case of isolated hospitals, in rural places and all, we can just make it available. It should have a proper network also. Network is also
Okay.
important in this sense. So with
That's
all those
right. Just
networks, yes, ma'am.
it's okay. Continue.
Yes, ma'am. So network is also important. The video clarity, bandwidth, everything, frequency, everything is important. So with all these facilities, we have to set up a clinics with convention light microscopy. We have to have a computer-based system so that we can diagnose it faster and easier.
All right. Thank you.
Thank you, ma'am.
Hi. Thank you for your presentation. I just have one question. So, does your institution have this technique? Have you
No, ma'am.
tried this technique
No,
anywhere
ma'am.
in your country? No. Have do you
Sorry,
aware?
ma'am.
Do you aware any of the institution in your country that you already use this technique? Do you have any institution in your country that already use this technique? Hello? I think they're freeze. think they're disconnected, I assume.
We cannot do robotic telepathology. Nambia? What's the other one name? I forgot. Ashira, are you there? No? Okay. Back to you, MC. MC Bell.
Dah tak sempat nak tanya.
Okay. Thank you very much for the Q&A session. So I just want to ask, do judges need 1 minute break, or we want to go through for the one last presentation?
You can go ahead.
We can go. Okay. So next we will be presenting the last presentation by Sporty J. Sparsha, C. Koda, with the research title, Silencer Appliance, Sleep Like a Baby.
A very good morning, one and all present here. First of all, I would like to thank UiTM Malaysia for giving us this opportunity. And today, we are here to talk about a silencer appliance designed for sleep apnea. First, let's see what is obstructive sleep apnea. It is a major sleep disorder because of repeated, complete, or partial collapse of the upper airway during sleep. Patients develop sleep fragmentation and oxygen desaturation. It occurs when the multiple supporting soft tissues relaxes. These conditions can lower the flow of oxygen to the organs and causes uneven heart rhythms. Common OSA signs and symptoms include snoring, absurd apnea, walking with a sensation of choking and gasping, unexplained tachycardia, restless sleep, sweating during sleep, nocturnia, bruxism, sleepwalking, sleep terrors, disrupted sleep, insomnia, nocturnal gastroesophageal reflex, and so on. Factors which increases the risk of sleep apnea are excess weight. Obesity greatly increases the risk of sleep apnea. Fat deposits around the upper airway can obstruct breathing. A narrowed airway. A narrow throat may be inherited tonsils or adenoids can also enlarge and block the airway. Nasal congestion. If at all the patient has difficulty in breathing through the nose because of an anatomical problems or could be due to any allergies, the person is more likely to develop OSA. Family history. Having family members with sleep apnea might increase the risk of developing OSA. Smoking. Smoking can increase the amount of inflammation and fluid retention in an upper airway. Smokers are 3 times more likely to develop OSA than people who never smoked. Treatment. There are several treatment options. It often includes lifestyle changes such as weight loss, cessation of evening alcohol ingestion, sleep position training, upper airway surgery, oral appliances, and CPAP, continuous positive airway pressure therapy. The only non-invasive alternative which can provide favorable results within a short time is an oral appliance. Oral appliances for OSA attached, it made attracted attention in the Western countries in the early 1990s. Through this poster, we are presenting an oral appliances, which is an affordable alternative in reducing sleep apnea and provides a better life to the patients. Let me examine you with the help of a case of a 49-year-old male patient named Babu reported to the Department of Orthodontics with chief complaint of disturbed sleep and snoring during sleep. On extraoral examination, patient had straight profile, acute nasolabial angle, obtuse nectolabial sulcus, On intraoral examination, patient had class 1 molar relationship bilaterally, class 1 canine relationship bilaterally, crowding in the lower anteriors, trauma from occlusion to the 2-4, 2-5 and 2-6. On cephalometric analysis, he had orthognathic maxilla and mandible, vertical growth pattern with reduced lower pharyngeal space. On radiographical evolution, with the help of lateral encephalogram, it was found that patient had orthognathic maxilla and mandible with vertical growth pattern and backwardly positioned mandible and hence reduced lower pharyngeal space. With this, my co-presenter continue with the rest of the presentation.
Coming to the treatment objective, so our treatment objective was to determine the effect of oral appliance in reduction of sleep apnea and also to determine the efficiency of this appliance in increasing the width of the pharyngeal space. So let me tell you how the treatment progressed. So pre-treatment lateral cephalogram and OPG were taken along with impressions of both the upper as well as the lower arc with the help of a putty impression material. So bite registration was taken using modeling wax with 4 mm of mandibular advancement. So upper block has an inclined plane of 45 degree with a groove in the lower block to accommodate the upper inclined plane. So then the bite was sent to the laboratory with clear-cut instructions on its fabrication and the appliance was fabricated. So you can see in the left side corner, that was the appliance which was fabricated. That's our silencer appliance. So what are the results obtained? So the patient was advised to use this appliance for a year. So it was noted that ESS, that is Epworth Sleepiness Scale score, had reduced from a pre-treatment score of 20 to 4. So there was significant improvement in the quality and duration of patients' sleep with reduced snoring, and the fatigue and the tiredness which the patient used to feel before had reduced drastically. So coming to the discussion, so several oral appliances were used in the past to treat obstructive sleep apnea. Through this study, an attempt was made to find an affordable alternative to conventional oral appliance used for sleep apnea. So there are many advantages as well as disadvantages in using this oral appliance, that is our silencer appliance. But I can definitely tell the advantages will outweigh the disadvantage. So silencer appliance is highly economical. It can be easily fabricated. It's less bulky. It's more comfortable, and it won't cause any discomfort to the patient. So conclusion, I would like to conclude my study by saying that with silencer appliance, there was significant improvement in the quality and duration of patient sleep with reduced snoring. So ESS score, as I said, had reduced from a pre-treatment score of 20 to a post-treatment score of 4. So there was drastic reduction in tiredness and fatigue as well. Thank you.
Thank you.
These are the references.
Thank you very much for the presentation. Now we would like to invite the judges for the Q&A session.
Hello, ma'am. Good morning.
Good morning, ma'am.
Morning. Right, so thank you for your case report, right? Interesting study. So I would like to ask, okay, I assume you treat this patient, right? This is your patient? Is this your patient?
Sorry, ma'am. The patient.
Is this your own patient? Do you treat them or is it your case?
No, ma'am. Actually, one of the PGs from our college treated, a postgraduate treated the patient.
So what is your contribution to the project?
We actually assisted him. We saw the entire process, the entire case, how it was done, and then we presented it.
Okay, so okay, all right. So you mentioned just now you have several measurement you use, to measure like sleep quality. You say ESS score. Can you explain a bit in terms of your measurement? to, when you say you have improved, the patient improved significantly in terms of snoring quality, sleep quality. So can you explain that a bit?
Yes, ma'am. ESS is nothing but Epworth Sleepiness Scale. It's just a questionnaire. It will contain several questions. So we'll give the patient, like pre-treatment, we'll ask him to fill in the form. So and then a post-treatment also there will be the same set of questions which he'll have to fill, and we'll compare the score. So ESS, like the questions may be like how many hours of sleep he's getting, if he is snoring during sleep, or if he's having any breathing difficulties during sleep. So these are the questions which are included in that questionnaire. So when we treated the patient, like when we saw the score, it had reduced from a pre-treatment score of 20 to 4. Actually, the ESS score, the normal range is around 0 to 10. So as the patient's score was around 20, the pre-treatment score, we concluded that he had sleep apnea.
Thank you.
Thank you, ma'am.
Dr. Indah, you want to ask a
Okay,
question?
okay, maybe one question from me. Okay, can you hear me clearly?
Yes, ma'am.
Okay, so in the okay, so is there any appliance that almost similar with the silencer appliance that are available in the market that you can compare to?
There's a CPAP machine, ma'am, that is conventional
Positive airway
pressure
pressure
therapy.
therapy.
So it's like a bedside machine with a mask. So the machine will be kept next to the bed, and the mask will be worn by the patient during sleep. So it will provide air to the patient, that is oxygen to the patient. So that
It
can be
almost
used.
works as a similar appliances.
Did you include that machine in your study as a control?
No,
No,
ma'am,
ma'am.
no. That was not quite affordable to
Affordable.
the patient, so no.
Okay, okay. Okay, that's all for my question.
Thank you, ma'am.
Thank you.
All right. Hi guys. Just one suggestion. What
Yes.
you presented just now, it will be good if you include that in your abstract, because just by reading your abstract, it is more on the silencer itself and OSA. But the fact is you actually did more for this particular project, right? Because you measure something, you did some questionnaire, so it's
Yes,
not
ma'am.
reflected in your abstract. Also, the device, is it newly being used in your institution? Because that technically that device has been around for quite some time, right?
Yes, ma'am.
Okay, is it newly introduced? That's why you are doing this report?
It's
Ma'am,
not actually newly
new
introduced, ma'am. It is quite available. So we'll give option to the patient itself based on his financial
conditions will
conditions,
decide which
which
kind of therapy
appliance
they
he
can go
needs.
through.
Okay, because I thought it is now being used in your institution. That's why you want to highlight it, because your conclusion
Mhm.
is not that this device can treat OSA, but technically it's been proven to be beneficial for OSA patient. All right.
Yes,
Yes, ma'am.
ma'am.
Yes, ma'am.
Okay. All right. Thank you very much. Very good.
Thank you,
Thank
ma'am.
you.
Thank you so
Thank you so
much.
much.
Thank you, all the teachers. Thank you, judges. Bye.
Thank you, ma'am.
Thank you very much for the judges and presenter for the Q&A session. For the judges, do we need to ask for the EL10, Ashira and Navya just now? Do you guys need another Q&A session for them?
For me, no, Bella, Nabila,
Okay.
no.
So for all judges, no, eh? All
Ah,
right. Then I think we can wrap up this session. So this concludes the poster presentation for today. Thank you all for attending. We hope you have learned and enjoyed the presentations, and don't forget to join us on the 13th and 14th of April for our main symposium event via our live streaming channel on our website. There will be research presentation and keynote lecture from our esteemed international speakers. You are also invited to the closing ceremony on the 14th April for the award giving ceremony. Your e-certificate will be emailed to you later after the event. We hope to see you there, and that's all from me. Thank you very much.